Thank you so much. It's great to be here. Senator Dole, thank you so much for having the research perspective here and for having this amazing conference. I feel so energized by this time of the afternoon. Usually my energy is not high, but it certainly is today. I also want to thank the staff of the Dole Foundation. Steve, thank you for that introduction. Laurel, you've been an amazing help in getting our panel together. Thank you. I also want to thank all the caregivers and the veterans and the service members. Without you, we wouldn't really have a research agenda. So we're going to talk a little bit more about research. I wanted to start, though, by telling you a little bit about the work that our group has done. In 2009, when the Iraq war was in high gear and there was a surge in personnel that were being sent overseas, we were funded to do a study, what we call the FACES study, the Family and Caregivers Experiences Survey. And what we did is we surveyed every caregiver who had had a veteran who received care at one of the at that time, four polytrauma rehab centers in the VA. We surveyed them. Some of you may have responded to that survey. You'll know because it arrived in a very large suitcase. It was a very long survey. And then after the survey, we sat down with about 20 caregivers and sat down with them for quite a long time and had a little bit more information, qualitative information that we gathered to help us understand what the experiences are that caregivers go through, especially when their loved one has gone through polytrauma. The thing that I took away from that study was the importance of caregiver stories. We've heard a lot of stories over the last couple days, and they constantly are inspiring to me and heartbreaking, and you realize that people's lives can change in just a short moment. And one of the things, I remember one important interview that we did as part of the FACES study. My colleague and I flew to Florida, and there were a number of interviews that we were doing in Florida, and we were going to people's homes. They invited us into their home to sit down and talk to them about their experience. And there was a woman, it was around right after lunchtime, so probably about 1 o'clock, and we had flown from Minnesota, so we were on Central Time. She was standing at the front door, behind the screen door, with her hands like this when we pulled up. And I looked at my colleague and I said, oh my gosh, we are in such big trouble. She's mad. And we got out of the car and I said, are we late? She's like, yes, you're very late. And I'm checking my watch and I'm thinking, oh my gosh, we screwed up the time zone. It's the Central Time, East Coast time thing. And she said, I have been waiting so long to tell somebody my story, and you're finally here. At 5 o'clock, we left their house. And she and her husband and her son talked to us for over 3 hours about their experiences. He was on leave. He was not injured in theater. He was not injured in combat. He was on leave coming back from visiting his daughter and was hit by a car and had a very significant brain injury. And their lives changed. They had retired. They were kind of done taking care of their kids. They had moved to Florida, and all of a sudden they had a son living with them again, and it rocked their world, and they needed to talk about it. So, with that story, I think that one of the things that often is difficult for people to understand about research is that it seems very ivory tower-ish. How do we actually, as Roxana said, how do you actually get those results, the research results, into practice in quicker than 17 years or 15 years if we've really made that much progress? My belief about research is that we're telling your stories. The data that we collect from caregivers and from veterans and from service members all create stories. And it's a different story than the story, your individual story. Everybody's got their own unique experience. We try and gather all those experiences together and make some sense out of what the commonalities are and what the differences are. And so even though a bench scientist who looks at petri dishes may say, I don't tell stories with my data, that researcher does need to tell stories with their data. They need to give us an understanding of what that research is going to do, how it's going to change things. So we have a very esteemed panel here. We've got a very diverse panel. And I think what we're trying to do today is talk a little bit about where the research is, what some of our challenges are, and how we can move forward. We're trying to lift the veil of what's been happening in a caregiver's life and a caregiver's experience. So I want to talk a little bit about our panel. We have got a very interesting group of people. We've got a health economist, we've got a neuropsychologist, we've got policy people, and we've got a clinical psychologist. And so we've got a lot of different perspectives to give you on where things are. So with that, I'm going to do a little bit of introductions, and then we're going to jump into the 3 questions: gaps, challenges, and future directions for our work. So the first person on our panel is Dr. Jim Malik. Jim is a professor and research director in the Department of Physical Medicine and Rehab at Indiana University in the School of Medicine and the Rehab Hospital of Indiana. He's a professor emeritus of psychology at Mayo Clinic and is board certified in clinical neuropsychology and in rehab psychology through the American Board of Professional Psychology. I should also note, I found out today that Jim's from South Dakota, so along with Tom Brokaw and Joel Skolton, we've got really good representation from South Dakota. Anybody else from South Dakota? Did I hear clapping? Our second panelist is Courtney Van Houtven. Dr. Van Houtven is a health economist at the Durham VA and at Duke University. Her aging and economics research interests encompass how family caregiving affects healthcare utilization, expenditures, health, work, and wealth outcomes of caregivers and care recipients. She's also interested in understanding how to best support family caregivers. She's testing the effectiveness of a skills training program for family caregivers of veteran patients referred to community-based long-term care, and she's leading a partnership with the Caregiver Support Program. As a co-I of a new VA query program entitled Optimizing Function and Independence, she's going to lead the implementation of the Caregiver Skills Training Program at 8 sites nationally. Our third panelist is Rhonda Richards. Rhonda is currently a senior legislative representative responsible for family caregiving, long-term services and supports, also called long-term care, and other issues at the federal level in government affairs at AARP. She successfully advocated for a number of provisions enacted into federal law and received the 2010 AARP Lynn Bodiford Award for Excellence in Advocacy. And finally, we have Army Colonel Jeffrey Grammer. He's the National Director of the Defense and Veterans Brain Injury Center. He oversees all aspects of the organization's mission, which is to serve active duty service members, veterans, and their family members with TBI through state-of-the-science medical care and care coordination, innovative clinical research, and educational program. Colonel Grammer's previous assignment was at the department, was as the Department Chief of Research at the National Intrepid Center of Excellence. So let's give a round of applause to our panelists. I'm going to move over here. And we've talked about doing this in a very conversational style. So we're going to go around and talk a little bit about the questions that we've been posed and asked to answer. And then we're going to open it up for questions from the audience in the last 10 or 15 minutes. So the first question that we have is, what do you see as the top 3 gaps in caregiver research or policy evaluation that need to be addressed in order to move the field forward? So, Jim, I'm going to start with you, and then we'll kind of move down the line. And, it's really more of a conversational style, so we can kind of, anybody who wants to kick in some comments, feel free to.
Well, I'm happy to kick it off. From my perspective, and this kind of reflects my own interest and that of the group that I work with, at the top of the list is really how best to help caregivers cope with the stress they have to cope with, build resilience over the long term. And when you look at the professional literature, you see a number of different approaches that have at least some preliminary evidence of efficacy. And some of those, as we heard today, have been translated into practice already. And those range from teleconferencing, support to workshops, day long or 2 day long, to groups that extend over a number of weeks to build coping skills and resilience and education, to more intensive kind of individual therapy. Another set of research has looked at in-home interventions, and again, we heard today that some of that is already being implemented. I think maybe the real question in my mind is what works best for whom, and that's, in research, that's often a question we delay until we are pretty sure something works, and along the lines of Dr. Delgado's encouragement to move things a little quicker into practice, I think maybe we need to jump ahead. Because at least in my experience, and for many years I was a clinician as well as a researcher, most people don't need a real intensive intervention. That many caregivers can do quite well with an occasional teleconference. I think one of the things we've identified in our group interventions for caregivers that they found most valuable, and again, we heard this over and over again today, was just knowing they're not alone, getting the support from other people. And that might be organized in support groups, it might be organized over the web, and we heard about a number of those kind of interventions. So I think trying to figure out, who needs what, when, and what's going to work best for those people is kind of first on my list.
Yep. Really important, I think. Courtney, do you have any thoughts on the top 3 gaps?
Sure. I think you heard this a lot earlier today, too, from the caregivers who were on the panel, and that is that we really have no idea what the long-term economic consequences of caregiving are for the caregivers, for the care recipients, for the family, and for the next generation. And I think part of this is, we'll talk about in terms of how we can ameliorate this, but we know a snapshot. So Joan's work at Minnesota did an excellent job of creating that snapshot of what happens after you are released with polytraumatic injuries and TBI. So we know 40% of caregivers quit their job, and that was in the very short term. We know that 72% of people took on debt or depleted their assets in a significant manner. If you did deplete your assets, you depleted around $2,500 on average. And as you know, there's no average person, and that can go up to people who reported $100,000 in debt after the initial injury and post-rehab period. But that's just one point in time, and what we really need is to understand what happens over the lifetime. I think it was Annie Remsburg who was talking about, I'm worried about my Social Security, and she's actually sunk in a lot of 22 years of working with the company, so she actually had built up some Social Security at least. But I think we also need to think about, so I'm worried about people retiring earlier and being able to quantify those impacts on them and going into poverty, into old age, which women in particular are at risk for. But also what happens to the younger caregiver like Rachel O'Hearn, who it seems like she's still working and being quite a leader and probably will be working when she moves to Texas. But if she had to quit work, that was really early on in her career. So you've lost one income potentially with the veteran being injured. And then what happens to you as a spouse if you have to quit work and you can't really enter? And so we really need to understand better over the long term what the impact is on caregivers and try to figure out ways to ameliorate it. As people said, we're not going to wait until we understand that long-term impact to do anything. And everyone in this room is already spurred into action, but that's one of my big concerns.
Rhonda?
I can actually build right off of that, because we do know from research that on average, family caregivers who are 50 and older, who leave the workforce to care for an aging parent, lose on average over the course of their lifetime about $304,000 in benefits and income. That's quite significant because most people don't even save anywhere near that much for retirement. So to lose that on top of this impact on savings and retirement security, that's certainly quite significant. I think some things I was going to mention were issues, and we heard it some this morning, around identification. Family caregivers do not often self-identify themselves. We heard that from some of our Dole Fellows this morning. And the system, the larger healthcare system, or maybe in some cases the VA as well, don't always recognize the family caregiver, identify the family caregiver, support the family caregiver. Yet we know that family caregivers play such a critical role in care coordination and day-to-day activities communities, advocating for their loved one, and things like that. So the need for more person and family-centered care, where both the individual or the veteran who needs services, but the family caregiver themselves are recognized as needing to be at the center of the care team and critical members of that care team and the support that they need. I think also we heard today about family caregivers and military veteran caregivers. The challenges of finding and accessing the resources they need that meet their own individual needs. You don't know what you don't know, and services and resources vary by community, and learning about it and finding what you need it can be very challenging sometimes. So being identified first and getting plugged into those systems that can get you to the resources you need is really critical. And I think that some of the challenges that were alluded to earlier too about the balance of everything. How do you balance working or needing to quit that, raising children and dealing with caregiving responsibilities and other family responsibilities?
Thank you. Colonel Grammer?
Great. Well, first, I just want to give a quick shout out to Senator Dole and the Dole Foundation for the opportunity to have this very important conversation, and thank you for allowing DivBIC and the Department of Defense to be here today. I couldn't answer this question without studies like the 15-year study, which is congressionally mandated and has a caregiver burden track where it specifically looks at gaps in care and sort of the plight of the caregiver. One of the things that came up from that study was that regardless of severity of head injury, half of caregivers report feeling a significant life-altering burden that affects their quality of life. 70% of children are reported to be affected when there is a service member with a head injury. And so the scope of the problem is actually fairly monumental. And one of the challenges is just dedicating the resources to be able to give it the investigation that it deserves. In addition, one of the things that we saw was the burden actually endures over time. And so it can be challenging because a lot of effort goes into the point of injury and the entry into healthcare. And a lot of people will rally around and case manage and so forth. But then eventually, after rehabilitation, folks go home, and the resources begin to fade, and the interest can start to fade. And it's very important and incumbent upon us to continue to follow the trajectory of these folks over time. In addition, there are challenges presented when folks are discharged from the healthcare system to the community, particularly with head injury, where after biomechanical rehabilitation needs are met and self-efficacy is obtained, there are often behavioral manifestations. And they may not make themselves evident in the constrained environment of a healthcare system. And it's only when you get home that you have the internet, substance use, the ability to act out in ways that could involve the criminal justice system that you may know that these are problems. And often, for example, behavioral health only becomes involved once an incident has occurred. It's very important that we try to identify those at risk and bring in assets on the front end to help guard against and prophylax against those adverse outcomes. And then finally, one of the things that showed in the 15-year study was that it's not a homogeneous population. The capacity for care with each individual family is highly variable. And unfortunately, when you're trying to identify needs or study this population, we like to control variables in research. And so with this inherent heterogeneous population, it makes research design and policy a lot more difficult.
Oh, yes, I dropped my mic, so I think is it still on? Okay. I think these are all really, you're beginning to see a little bit of overlap in our discussions of what the gaps are. I would throw out 3 more possible gaps. One is tagging on to what Roxana said today about implementation and how do we actually change or think about implementation of programs or about different interventions into clinical practice. The VA is one of the best institutions to testing implementation work. It's got the whole query program was built around this and has changed, but there are a lot of people at VA who understand how to effectively implement programs and projects and legislation. And so I think beginning to understand a little bit more about what effective programs are out there and then how effectively to get them to people in a timely way is an incredibly important area that is lacking right now in the caregiver literature. And then to piggyback on to what Rhonda was saying, I think that there is a real importance in beginning to redefine care, not just as patient-centered care, but as family-centered care. And how do you begin to integrate caregivers into the clinical environment and into the encounter? We can go ahead and say that we need to be able to do this, but as Dr. Skolton said today, physicians are not very good at it. And I think anybody who's struggled a little bit with their care team knows that even with the best intended providers, they often don't have the training to adequately integrate caregivers into the healthcare team, not as a proxy and not as an ancillary to the patient, but as a member of the care team who has decision-making responsibility, who can be there as a member of the team that is providing care. They are providing all the care in the other 5,700 hours per year that they're not in the clinic. So that's another area. And then the last one I would say, based on a lot of the, and this is certainly reinforced with some of the caregiver stories today, especially with and Jason and Annie, is that there are a lot of subgroups that we don't know much about. We don't know a lot about male caregivers. We don't know a lot about LGBTQ caregivers. We have almost no data on them. We don't have a lot on parents. And in our study, we found that 65% of the veterans who had polytrauma and received care, inpatient care in the polytrauma rehab centers, were parents and not spouses. And I think that that's another group that I think is often, Annie pointed this out so eloquently today, that's another group that I think we just need to have more information on, because their experience is so much different than if it's a spouse or a sibling, and for older caregivers, maybe their children. So that, and I guess the fourth one I'll just throw out there, I saw this on the board out there, but it's come up in our work with cancer caregivers as well as the TBI polytrauma caregivers, is issues around intimacy and sex after injury or during with chronic conditions. I think that the emotional connection and the relationship aspect of care is incredibly important, and a lot of caregivers have a lot of questions as to what is right, what's ethical in some ways when people have brain injuries, what's physically safe. And so it's an area that I think we dance around because it becomes very uncomfortable. But it's something that is definitely on the minds of caregivers and on the care recipients as well. Any other comments on that?
I'd just like to pick up, I want to second your point around subpopulations, because part of providing person and family-centered care and really tailored supports that go to the needs of the individual caregiver is thinking about cultural competency and knowing the caregiver, knowing how needs and whatnot vary individually and across different populations. So I think that's really important.
And actually, your point about intimacy, I think, is very poignant. At the National Interpretive Center of Excellence, which is a sort of a multidisciplinary system of care, that we actually have someone who's been trained to give essentially intimacy guidance. And what we find is that there's a lot of questions, a high prevalence of dysfunction within those relationships that affects the quality of the marriage. And the challenge is there's not a lot of real good ways to measure it in this population, and there's not a lot of people trained to actually do something about it. At least when I went to med school, there wasn't a huge class in the polytrauma survivor, how to give them guidance on intimacy. So there's a lot of work that needs to be done. And I'll often joke in psychiatry that, people will tolerate just about any degree of severity of illness as long as they don't have to gain weight or lose, sexual capacity. Mm-hmm. So you're absolutely right. It's critical, and it is underserved.
Yeah. Courtney?
I just wanted to bring up something that is really unique and that's just coming out, and that is that as a part of the evaluation of the VA Caregiver Support Program with my colleagues, Meg Cabot in central office and her colleagues back in the corner, Meg Campbell-Kotler and Jennifer Hennius, we have been working really hard to encompass the caregiver perspective. And I think we're talking to the converted in this room, but we really need to cater better to the caregiver's perspective. But in order to do that, we need to hear from you. We need to hear from people who are happy with services. We need to hear from people who think we could improve on things. And in the work that we've been doing the last 2 years, we have really nascent understanding of the impacts of the comprehensive program of assistance on caregivers and veterans, because people were willing to fill out, 1,400 people filled out a quantitative survey, 100 people were willing to spend 30 minutes with our interviewers telling their stories on what services are meeting their needs best and where are the areas that they could still need help. So really, for me, it's really critical. I do a lot of work with claims data and huge national surveys, but it's really hard. We need these other efforts in order to understand the caregiver's perspective.
I think that's the perfect segue into challenges, our next question. Kind of moving on to this next section, which is, what do you see as the 3 top challenges for conducting caregiver research, either with veterans or service members, military or veteran caregivers, or with the civilian population too. And that goes for policy evaluation too. What do you see as sort of the biggest challenges for that? Jim, do you want to pick up on that?
Well, I think if you'd ask most rehabilitation researchers in any area what's the biggest challenge to doing what they do, it would be lack of funding. And I'll jump right on, because I really think it is a major issue. And I understand why, because when you think about this kind of work, understanding caregivers and understanding how to help caregivers, more effectively, it's hard enough to get funding just to offer the program. Then when you introduce an evaluation component, that's additional funding that just isn't there oftentimes. But I think it's so important to have that evaluation component. Again, kind of it's sustaining the theme of doing things that can be applied fairly immediately. I mean, I don't think that these have to be randomized controlled trials. Unfortunately, you can get funded for those. What you can't get funded for are more applied interventions and more of a programmatic sort of evaluation. But as I said, I think that's so important, because the real question is what we're doing going to have a sustained effect? When I go out with my friends, I always feel good when I come home. The next day I have the same problems. And I think, a lot of our support groups can have that very limited impact. That's, or the social media stuff. That's all very worthwhile, but it'd be nice to find some things that have some momentum to them. And, that's why we need that evaluation component. So, we need more funding.
And I think the struggle with the funding sometimes is that it's often tied to the care recipient. So you have to frame your research proposals and your research questions around the care recipient, and then add in the caregiver component, because it's a lot of funding agencies aren't willing to pay for a grant looking at caregivers specifically. Always has to be connected as an ancillary to a patient or a care recipient question.
And now that you've said that, my second on my list, and again, my colleagues in research will probably stone me as soon as I leave the building for this, but it's too much rigor. Again, to get funded, you have to have a very rigorous study, which may not apply to most people, and is going to have a very limited impact.
Yeah.
Again, I think, especially in this area, what we need is, one of my more rigorous friends, and even he will point out, we probably don't need to do a randomized controlled trial on the wheelchair. Pretty obvious it helps people who can't walk. And I think a lot of the things we do are kind of in that same ballpark. It's pretty obvious they're going to help. Again, the question is how to deliver them in a way that results in a sustained help or a sustained impact. Yeah. And that doesn't require the most rigorous kind of research. So.
Yeah. Courtney, did you want to add on anything to the issue of targeting caregivers and asking them to be involved in research? Once you get the funding, you actually need to get people into your study.
Oh yeah, you're talking about recruitment rates.
Yes.
Well, yes, getting people who are dissatisfied or have not been able to get services often don't want to talk to you, and those are really the people that we want to hear from. But maybe I'll switch back to the realm that I think I have a unique perspective on, which is kind of economics and the economic costs of caregiving. And one of the big challenges is we don't have long-term data on anything besides work outcomes. So we economists look at how does caregiving impact work, because that's in the data. But I think we want to have better data sources and have them available over time so that we can understand the full economic costs. So I mentioned that before, we focus on work, but what about lost productivity at work? What about not being promoted because you have to miss so much time, even with flexible schedules that companies are starting to offer? What happens when you're having to leave work and go help the veteran on a regular basis? The other thing I want to think about, and these are harder to think about how you would get data, but in the research that Joan has done and in TBI, financial impulsivity is a big issue. What if we could use credit reports and look at really unique data sources and understand for a family what impact that impulsive spending has done on their, get at the back door, get some credit reports and understand it that way. Overcoming data limitations is really a big problem in this area. And hopefully in future collaborations, RAND is going to be doing this, it sounds like, and I know there are a lot of questions on the board for Terry, as well as hopefully with the VA Caregiver Support Program, that we'll be able to keep collecting longitudinal data on health outcomes, burden outcomes, successes, positive things that have come from caregivers interacting with the system, and also some of the economic challenges.
Rhonda, do you want to pick up next?
I would be happy to. I'm going to speak to this from the policy perspective and thinking about when you're advocating for change at the federal level or state or local. Given federal budget constraints, for example, that were alluded to earlier, people often want to know, how much does something cost? The lower the cost, the greater likelihood of it actually being enacted into law. We know, for example, that there are about 40 million family caregivers in this country, about 5.5 million are military veteran family caregivers. But if you put a dollar amount on the value of the unpaid care that those about 40 million family caregivers provide annually, it's about $470 billion. And we know that military veteran caregivers, family caregivers, help their loved ones stay at home where they want to be, potentially preventing unnecessary hospital visits, unnecessary emergency room visits, keeping them out of more costly institutional care such as nursing homes. But when you go to advocate for different policies that help support family caregivers in different ways, again, if they have a cost associated with them, there's often the question of, okay, what else are we going to offset? What can we find savings somewhere else in order to pay for this particular intervention? And then is this intervention going to be effective or not? So is something effective? Is it going to work? Is this intervention going to, in fact, save money? If you support family caregivers by doing X, Y, or Z, is it going to help prevent that unnecessary institutionalization, or is it going to prevent costly hospital readmissions and save money in Medicare or the VA or wherever it may be? So having research that shows the cost savings of policy proposals is very helpful in terms of advancing those in Congress, for example.
And I think getting those data sources to figure out what those costs are is often really challenging. Yeah, thank you. Colonel Grammer?
So I think one of the challenges in doing both research and setting policy is that the military service member and veteran population is a very mobile population. While they're on active duty, they'll often move between military bases, and then once they ETS or retire from the service, then they transition over to the VA. So you're geographically moving, and you're moving within healthcare systems. That makes research very challenging because often you get PCS orders and move, and if you're doing once a year phone calls, it's very hard to reach out to folks. Likewise, policy almost has to be at the federal level because any state policy may not capture someone as they kind of move through that system. In addition, we've already talked about the reasons for this. I mean, the caregiver burden and trying to alleviate that and study it and to help the problem costs money. Mm-hmm. And this is a little bit potentially contentious to say, but particularly for the invisible wounds of war, convincing people to resource that can sometimes be a challenge. Someone with an amputation, for example, or some other visible sign of injury, there's a natural human tendency to want to sympathize with that plight and want to pour resources into that. But someone who is acting out at the mall because they become overwhelmed by sensory stimuli, we tend to view that behavior sometimes differently, and it's important that we educate policymakers and decision makers to help them understand that that is also as much of a symptom of injury as the amputation. And then finally, one of the challenges is we don't actually really have really good validated instruments measuring caregiver burden. We have some, but we need to actually refine those even further so that we can better understand the problem and then track the interventions that we make to show that it changes the degree of suffering and is cost effective and so forth.
Great. I think I would add just a couple. One, I think having moved from the VA to Mayo, I have a different perspective on having third-party payers come in too. And, there's not a lot of incentive for healthcare organizations to have caregiver interventions that are, even when they're effective, because there's no reimbursement from health insurers to pay for these caregiver interventions. So really it sometimes comes down to it's going to be good for the patient, so we'll intervene with the caregiver, or in the long run it may pay off, which kind of ties back into what Rhonda and Courtney were saying. But without proper reimbursement, it's really, really hard to get providers to spend their scarce resource, which is their time, on doing additional work to engage and bring in the caregiver when they're not going to get reimbursed for it. So I think it's a huge policy and a huge research challenge that we have. And then the other one that I would certainly say funding is probably the biggest one, and engagement and getting caregiver engagement in our studies is a second. But the other one is access and data sharing. I know that at the VA there's a lot of restrictions on how we reach out and connect with caregivers, and so what's convenient for caregivers, like a web survey, is really difficult to do because of restrictions at VA. I don't know if that's how it is at DoD too, but there are a lot of privacy barriers in the way for us to actually reach out in a way that is accessible and convenient for caregivers. And we know that time is of value to caregivers, and so making sure that we are contacting people in the most accessible and easy way for them is critically important, but we've got some challenges and barriers there too. Okay, anything to add on the challenges part? No? I could go back to gaps too. There's a lot of gaps that I'm still thinking about. One gap that I just thought of when you were speaking is this issue of stigma. And that I think that a lot of caregivers experience stigma, especially when there are visible wounds, but maybe even more so when there are invisible wounds and you're at the mall or you're at the grocery store and somebody's acting out. And I think that caregivers often feel that, which certainly can affect their own well-being. And we've actually shown that in our data with polytrauma patients as well. Okay, so third question. I think we're doing great on time, so we'll have plenty of time for questions as well. So what do you see as the three most promising areas for growth? Where can we begin to really make a change as we move forward in this area? Jim, I'll throw it down to you.
I think a very, very good opportunity exists in trying. Let me back up just a minute. I think we have a fairly substantial set of data now indicating that caregiving does result in stress. Over time, it can result in some significant emotional stress and even disorders. Has a financial impact, both in the long and short term. So we know that there's some real liabilities to caregiving. I think on the other side of that, the opportunity is what can we do to prevent those things from occurring? And we have some preliminary studies suggesting that a stitch in time does work, that some initial education about what the veteran is dealing with, what the person with the disability is dealing with. It's surprising to me, again, just in my clinical practice, how relieving it is for people to understand that the person isn't getting angry because he's a bad person. It's because he has a TBI or PTSD or some other disorder. I think for those of us who work professionally, you might think that's obvious, but for the layperson, oftentimes it's not. We attribute that to the person rather than to the disorder. So just, getting them off the hook in that way can take off a lot of stress. So some education about those sorts of things, some reinforcement of basic coping skills, the kind of interpersonal support we discussed, the financial conflict, an opportunity for respite. A few things like that may make a huge difference over the long term. Seems like they would. We need to test that out.
Good, thank you. Courtney?
Well, so I think for me, the most exciting area in caregiving research for military and veteran caregivers has been starting to become a partnered researcher. So I think for the last 18 years, before I met people in the Caregiver Support Program or became affiliated with the Query Program, I was in my office doing my work, trying to think of ways to support caregivers, and at most it would only happen at one medical center. And I enlisted important people from central office to be on my advisory board and help me in case it worked and how we could roll it out. But one of the things that's been incredibly gratifying for me, and also I think speaks to the timeline of research, which everyone is frustrated with taking too long, and increases the relevance of research, is working with operational partners. And I was lucky enough to be able to partner with VA Caregiver Support. I've said it before, and I hope I will be collaborating with them for a long time. But when you can, as a researcher, find out how the program actually works, what are the pitfalls, what are the strengths of the data that they have, what are the different perspectives and pressures that a field is facing, you really can do a better job of understanding how does this program impact people, how is it helping them. And I think it has led to a better product. I mean, it also seems more important, so it's personally gratifying. Instead of having like 10 citations on a paper, this could actually do something. So it's really exciting from a research perspective. But I think from that, this last 2 years of directing this evaluation effort, we've found that the comprehensive program of assistance really can increase access to care for veterans in primary care. And that hopefully will have a positive impact on the family members and the veterans in the long term. It is effective in the very short term, reducing feelings of financial strain and reducing emotional strain. And so but we really had to design our study with our partners in order to really get at it the right way. And I think that for me is the most exciting effort and can speak to the timeline. So I hope a lot more partnerships, and I've heard about so many new programs today that are just being rolled out with these private companies and nonprofits, and I hope you guys will see the beauty. I know you're going to just roll them out, but evaluation is really important, and we can learn from doing an evaluation of that. So hopefully you'll also incorporate sort of evaluation plans in those, so we can really know what do caregivers want, what are the best modes for these busy younger caregivers. Is it online? Is it in person? Is it one-on-one peer support? Kind of informing things and being able to synthesize what's happening out there would be really valuable.
I'll just piggyback onto that, because I think that, Courtney and I have both sort of seen the light of partnered research, I think that we should be 5 feet away from caregivers in our work. I don't think we should be sitting in our office and crunching numbers as much as we need to be in front of caregivers, and that might mean collecting more qualitative data, but we need to be close in proximity. We can't have the work that we do actually be effective if we're just publishing papers and having the academic products. We really do need to have those operational and clinical partners, which is just critical for things to move forward in order to shrink that 17 and now 15-year gap into sustainable implemented projects or programs. So, thanks. Rhonda?
I think there are several areas here for real growth and opportunity. One is really leveraging learnings and experiences from caregiving across different populations. I work obviously older adults in family caregiving, but AARP works in sort of family caregiving across the lifespan, whether it's child with a disability, older adult, aging parent, spouse, sibling, military veteran. We look at family caregiving broadly. And there was, as was mentioned earlier, National Academies of Science, Engineering, and Medicine study earlier this month called Families Caring for an Aging America. Now, the specific charge for this study was looking at family caregivers of older adults who are 65 plus. However, the study also acknowledged that the recommendations likely pertain to family caregivers of people of any age. And indeed, some of the recommendations actually spoke to specific things that the VA could do. So as you're looking at opportunities for policy and research and things like that, I think that report is worth looking at as well, because it mentioned the VA in a number of the recommendations. I'd also like to point out that one of the first recommendations there was the concept of a national family caregiver strategy. And there is actually bipartisan legislation called the Raise Family Caregivers Act that is supported by the Elizabeth Dole Foundation, ARP, and 50-plus national organizations that would require the development of a national strategy to support family caregivers, whether you're a military veteran family caregiver, or caring for a child with autism, or an aging parent. We heard a couple examples earlier today of someone caring for a child with autism, an aging parent, and the spouse of a veteran. And I just want to say that this legislation was passed unanimously by the U.S. Senate last year. It is pending in the House, so feel free to urge your House member to pass this bill before the end of the year. Again, it's an opportunity to bring different agencies and stakeholders and communities together to share learnings and collaborate and coordinate. Some other examples of leveraging support: there's a family support research and training center that looks at leveraging knowledge and learnings of people caring for children and adults with disabilities across the life course. So for example, someone who has a child with an intellectual and developmental disability, they have that disability for their life, similar to a military veteran caregiver caring for someone who is injured by the wounds of war in their 20s, and they're looking at a long caregiving trajectory. There could be lessons learned there. The ARC, for example, has a Center for Future Planning to help parents who may be caring for an adult child with an intellectual and developmental disability, and they're thinking about who's going to help care for my child after I am gone. Similar to some of the issues we heard today from some of the Dole Fellows who are wondering, who will help care for the veteran in the future, and those long caregiving trajectories. There are also innovative opportunities at state and local levels. And I have actually an exciting example. This is where research actually only took a couple years to translate into policy change. No 15 years here. This is like a couple years. A couple years ago in 2012, there was research that showed about half of family caregivers perform medical nursing tasks, wound care, medication management, complex specialized medical equipment and things like that. But family caregivers didn't have the training to know how to do this. They kind of learned just on their own or by trial and error. Not a good way to go. 2 years later, the first state passed the Caregiver Advise, Record, and Enable Act, or the CARE Act. This is something that ARP offices and other partners in different states have been promoting. Now 33 states have passed this legislation. It varies a little bit by state, but it does three things. It requires that the name of the family caregiver is recorded when a loved one is admitted to a hospital, caregiver identification. The family caregiver is notified when the loved one is going to be discharged to another facility or go back home, and that the hospital has to provide an explanation and live instruction of the medical tasks that family caregiver is going to be doing when they go back home, so that they have that training and support prior to discharge to help ensure that smooth transition when that person goes back home. Oklahoma, the first state to pass it, it was the story of a military veteran caregiver who shared her story and helped show the compelling need for this kind of change in public policy, and worked with AARP Oklahoma to bring about that change. So it can happen, and that's an example. We also see in the area of paid leave, some states and localities are doing that for family caregivers broadly across populations, and we've heard companies that are doing this as well and providing flexible workplace environments. Real quick, the VA has also been a leader on telehealth. We've heard that today. There's opportunities there for that to support family caregivers. So as the VA is looking at telehealth, our opportunities being maximized to leverage that technology as well to support the family caregiver.
And I think the CARE Act is now passed in 32 states?
33 states and territories since 2014.
Yeah. Which is great progress in a very short time. Okay, thanks, Rhonda. Colonel Grammer?
So promising areas. I think the DoD and the NFL got something right with incident-based screening for traumatic brain injury, unless you're Cam Newton apparently. But in the beginning of the war, it was symptom-based. So if you were around a blast or something, unless you reported proactively that you felt unwell, you would often go unnoticed. Now, if you're even remotely in a situation where a head injury could have occurred, then you undergo a very systematic evaluation to screen for symptoms and then get appropriate treatment. This is important because a lot of people, come back from conflict, and particularly in the beginning part of the war, and there were behavioral changes, and family members saw this, but we didn't have an identification disease state why. So the very fact that we're beginning to pick this up, and it helps predict the amount of care that people need, to help explain to folks what might be happening as opposed to just attributing it to the individual personality style, I think is absolutely huge. The VA also does a very nice job when you transition over from the DoD to the VA. Both the departure and the entry have very comprehensive evaluations now to screen for a variety of ailments. Again, getting away from this patient reporting and instead screening across the board. So the more that we can do that, certainly the better. Another nice thing has been the method by which we deliver care. So the National Intrepid Center of Excellence and the Intrepid Spirit Centers, which have been created with the help of Mr. Arnold Fisher and the Intrepid Fallen Heroes Fund, have developed these programs that offer multidisciplinary, comprehensive, patient and family-centered care. And what we found, particularly in the persistent post-concussive population, is without that model, folks would bounce around from subspecialist to subspecialist, often with fragmentation of care, polypharmacy, medication interactions, no coordination. By getting it all under one roof in sort of an intensive fashion, you can actually make some genuine progress. So getting everyone working together instead of this kind of fragmented stovepipe care has definitely been an evolution that is very promising and hope to see more of. And then finally, I'm fairly new to DivBic. I came into the organization back in March. We were getting ready to have our 25th year anniversary. DivBic has been working, the DoD and the VA have been working together in the organization DivBic for, over 2 decades, and we were doing it before it was even cool to do. And so, I think that is also very promising. This is something that we need to do more of, because even though we're different, within the sort of federal system, we're different agencies, we take care of the same group of people, and we've got to find better ways of having a unified electronic health record, which is hopefully coming, and having that care be more seamless as they transition through, and making sure that we're doing research and we're setting policies that's coordinated between both agencies.
Great. I would just add one more. I think that we're beginning to see some overlapping here too, which is a lot of the caregiver research was sort of the birthplace of caregiver research was in Alzheimer's and in stroke. I think that there's a lot to learn from what has been happening in those areas for chronic disease management and for caregivers who are kind of moving into the chronic disease or chronic condition or chronic care management. That literature is big, it's strong, there are evidence-based interventions, and I think that we can begin to build on those not just for Alzheimer's and stroke, but also throughout the life course and for other conditions, whether it be TBI or diabetes care or ALS. I think that there's a lot to learn from that body of literature and the people that have been doing work in that area as well. Is there anything else that the panel wants to talk about really quickly? I do want to open it up for questions. I know we're running low on time, so I'd love to open it up for questions. I do want to say one thing, which is we stand on your shoulders. Because of you, we're able to do the work that we do, but we really do need to build better partnerships in order to move the research forward. So thank you for being such good advocates for us as well. Please.
Good afternoon, and thank you for all the information about your ongoing efforts, which I very much appreciate. Having been a caregiver since 2005 for my brother, I've actually seen how research moves forward and implements programs and services that can change lives of disabled veterans and their caregivers. So thank you very much. I'd also, to Jim, like to say go Hoosiers. And lastly, and I'll direct this to Colonel Grammer, but certainly anyone on the panel could chime in. Over the past 11 years, I've amassed a lot of data about my brother's injuries, his progress, and his care. And during that time, he's worked very hard on his recovery. but I have information, thousands of pages from the Army, from the VA, and now, thankfully, from many civilian providers, and we are so grateful for the collaboration of CARE. My concern does relate to the Unified Electronic Records and how we're going to protect that. Obviously, these records contain a lot of data about my brother's condition, his social security number, his birth date, his address, sometimes his phone number, sometimes mine. And I want to know how we're going to secure that. And as a caregiver who is 13 years older than her care recipient, I am concerned about how that data would transfer to the people that will follow me when I age out of this role.
All right, thanks for that question. Does somebody want to talk a little bit about the Unified Record, what it is and where it is? Do you?
Certainly a bit outside my expertise, other than, the bid was won. They are, getting ready to deploy something that is supposed to be more seamless between the two entities. I think that the question was about privacy rights, and I certainly respect that. I would say a few things. Now, fortunately, if it's done right, there are a bunch of safeguards that should be put in place for any time someone goes and looks at data, even for quality assurance or research or anything else. We take very great effort to anonymize data and make sure that if it's stored anywhere, that it doesn't have any identifiers that can be backtracked to any individual. There's an effort to create a unified database, something called FITBR, which is the Federal Interagency Traumatic Brain Injury Registry or something, I think. Get that right. And so they actually have this 13 hash, number that is impossible to kind of backtrack into an individual. So anything that gets uploaded there is sort of anonymized. The DoD's done away with Social Security numbers. When I first joined the Army way too long ago, your last four was mandatory at any time you showed up at a desk. What's your last four? Now that's gone, fortunately. We probably have more work to go, for sure. And you're absolutely right. We need to be very careful. The enthusiasm to look at this and the enthusiasm of researchers shouldn't outpace the privacy rights of individuals.
I'm not as worried about it in the research setting because we have so much training and we're so scared to ever have a breach of confidentiality, but I worry about it more from just the fact that you have so many providers and you're moving across systems, but I don't have an answer for that. But
what DoD or VA are you using? Right now, all of us, they still use our class 4 is common. We use DoD numbers on our market side.
Let's use class 4.
from research, you use scrambled SSNs that you don't have a key to translate them. So, and then you strip them often and you put a fake randomly generated study ID to make it even more secure. But that's kind of what we do as researchers.
The DoD.
I think that.
Oh, I'm sorry. Oh, the DoD. Just so you know, when you're right, if you print out what do you call it, a visit sheet, it no longer has your social security number. It's got this unique kind of DoD identifier. Your military ID used to have the social on it. That's gone, and now it's just a unique identifier. So the DoD, I don't know much about the VA, unfortunately, but the DoD certainly is trying to move away from no socials, and there was some end date where that was actually supposed to be completely phased out.
Is there another question back here?
And to follow up with Jennifer's question, and I think it's important, is that in 2007, when the Dole-Shalala report came out, there were a number of gaps and barriers that were identified back then in terms of what needed to be addressed on the future level. And unfortunately, today I'm hearing some of the same things that were identified in that report as remaining as problems to this day. I think that what we have done a great deal of and done a good job of is identifying where the problems are. And I think dedicating more time and money for the research for that may be somewhat limiting for us in order to move forward to advance those things. So the Institute of Medicine's 2001 report showing a 17-year deficit or time delay, we're in 2016 now and it's only decreased 2 years. So with that respect, I would encourage us not to sort of focus on what the problems are, but rather how to get the answers at this point. Electronic health records was addressed back in 2007, and I testified at that hearing. The other points I would like to make in terms from a research standpoint, and this doesn't necessarily affect me as a personal caregiver, but it would make my journey a lot easier, is to have advanced approaches to assessing traumatic brain injury and to training the examiners or clinicians to be able to integrate the voice of the caregiver better into the process. Because I know that personally, from my standpoint, and what Jason was speaking to earlier, is that I shouldn't have to also be the clinician in this mix. And so what I really wanted was someone to know the answers and run with it without me needing to suggest them and to have those implemented. So, excuse me. So what I would like to see is the system do a better job of what it's supposed to be doing to some extent, or at least identify some of the shortcomings in the system to maximize the resources that we need for ourselves. Thank you.
Hello, I'm a caregiver. This is my veteran. And prior to quitting my job and becoming a full-time caregiver, I had aspirations. I went to college. I did almost 2 years of law school before I decided I didn't like lawyers. And I've amassed, okay, phew. And I've amassed a great deal of student loan debt. I don't know if any research has been done to talk about caregivers that have amassed student loan debt and have no real hope anytime soon of going back to work. But it is something that is a reality for myself and many of the fellow caregivers that I speak with on a daily basis. I know that there's policies in place that forgive student loan debt for disabled veterans or disabled people, for police and fire if they serve and teachers if they serve a certain amount of years. Has any discussion or any policy or any research been done or thought about to help caregivers with that burden? Because it is a reality.
Courtney, I'll look to you because I think you're the only one who's done a lot of
nobody has looked into that in the U.S. I mean, it seems really obvious that that would be kind of like programs that think about, okay, I quit work. Maybe the time I'm spending caregiving should be credited to my Social Security benefit later. So those kinds of things are just that Social Security example. That's very nascent in the U.S. and has only just started being discussed, I believe. And these are things caregiver policies in Europe do. In Germany, you get donations to your retirement as a caregiver. But I haven't heard of anything that has addressed the student loan debt. But I think it's a great idea.
I think one of the things, and kind of piggybacking on the question that was brought up over here, one of the things that I really try and work with people on, and I do a lot of consultations with physicians at Mayo, trying to help them with their research. And one of the things I really try and stress is, what do you want to solve? You know, it's not just, oh, I have this really interesting question and I want to answer it. It's, what is it going to look like at the end? So if you know that the problem is debt, and you know that people are accumulating debt and they're not going to be able to get out of it. And a lot of the people that we interviewed were one bad event away from poverty. And that downward cycle of poverty is a very difficult place to get out of. And so if you know that that's the issue, work backwards. And, you know, have your data, your study design and everything go backwards, but you want an idea of what the solution, what the intervention could look like. And a lot of that could come from qualitative work done with caregivers, and then try and figure it out. It's almost like a paradigm shift. We really have to begin to think about what the solutions are, what they could be, and then figure out how to do them. And that's not typically how we work.
And just one last thing, to put it in perspective. Outside of my mortgage, my student loan debt is the biggest amount of debt that I have outside of my mortgage. And so that's a big issue.
Yeah.
So.
Do you have another question?
Yes. My question is for Colonel Grammer. I am a caregiver as well as a psychology student, and I am in the 15-year study. I've been in it for a couple years. I've written a lot of papers. I'm sure that my professors get very tired of everything being military focused, all of my papers, but I've done a lot of research and I can't find much on military children and how they are affected. Are there any plans to add? I know that they do ask some questions in the caregiver study. Do they have plans to expand that further to touch on how children are affected by caregiving, PTSD, and TBI?
Yeah, whether or not they changed the questions, Lou French is the PI on that. I'm not sure. I will say that at the recent International Brain Injury Conference, there were multiple publications specifically addressing the impact on children, and there's a fair amount of data that looked at declines in grades, acting out, and an overall kind of social developmental delay that can occur when there's a service member with an injury. But as far as I know, I'm not aware of a drastic change. Ms. Smith, Johanna Smith is in the audience and is our lead to the 15-year study. Are you aware of any changes to 15-year? She doesn't have a mic, so I think she's nodding no is the short answer. So, but
Yes, thank you. So in the next 3 to 4 years, I do believe that the plan is to expand the look into children. The mandate is to look at families, so to look at children further in the next few years is part of the goal.
Just to add on, for the VA, you need approval from the Secretary of the VA in order to do any kind of research with children. And so on the VA side, it's going to be really difficult to do. So I think it's great that if the DoD and DivBit could actually move that forward, it would be a wonderful addition to the literature.
One more. We have one.
Thank you very much. Very, very informative panel.
I can barely see you around this podium.
That's okay. You don't need to. I'm short. Thank you again, Senator Dole, Steve, for putting this together. I look forward to hearing Terry. But one of the things, let me suggest to the organizations who are still in the room and to the caregivers themselves, is when we began our effort and with the intention of sharing things with others, that we created, thanks to Booz Allen Hamilton, as Steve has called out, we created vetted metrics. And it's very important in everything that we're doing with our caregivers and their families for us to be measuring our own, to have program evaluations based on not just input, but on outcomes, that we are able to have results reporting, that we're able to report our impact. And it's not just counting heads of how many caregivers we might have touched, but it is what difference does it make when we touch them. You know, I mean, I can touch anybody, but, you know, they may not like it. So the difference is, so we have, thanks again to Booz Allen and others that we've worked in, we have survey instruments that we are willing to share with any organization or any caregiver in the room that can be utilized to help you develop your program evaluation. And I would ask the panelists and charge, hopefully, Steve, this is something that EDF can lead on, is how do we come up with some of those common metrics that we are going to all use so that every organization is able to report through Hidden Heroes the difference that it's making, and also the instruments to measure caregiver burdens. You tell us what those are. You give us some of those. We'll add those with the vetted metrics, and then we'll all be talking some of the same talk and make sure that we're having a collective impact. Thank you.
I think that's a great point. We don't have a lot of continuity and consistency with measures, so we're really sometimes comparing apples to oranges, which is not helpful in the long run. I think we're all out of time. I know that there's still some questions. I think any of the panelists would be happy to meet you in the back of the room and talk about those burning questions that you might have, and we want to thank you very much for helping us out on this presentation and being here and listening to us.